Perfect. And we'll let people start to come in. Perfect. It's always so exciting as people are entering a room, and I don't know, I always have so much energy in co-moderating these events. It's exciting for me to connect the individuals that are out there as clinicians, as practitioners with disabilities to the community, and to, in many ways, directly combat assumptions about who can or cannot be clinicians. So I get so excited about these panels, and I know that for the folks joining us today and for those watching the recorded version, you are going to be equally excited when you hear from this group. So welcome and good morning, afternoon, or evening, recognizing that we have people joining us from all over the world. So wherever you are in the world, we are so excited that you're here with us. Welcome to the Docs with Disabilities Allied Health Panel. My name is Lisa Meeks. I am the founder and co-director of the Docs with Disabilities Initiative, and I'm newly and excitedly a professor of medical education at the University of Illinois College of Medicine in Chicago. I also retain an associate professor designation with family medicine at the University of Michigan, which has been my home for the last almost decade, where I have the distinct pleasure of working alongside my co-moderator through the Center for Disability Health and Wellness. I am a person with an acquired disability at the age of about 42. I have a degenerative autoimmune disorder that at times impairs my mobility. And I am honored to be co-moderating today's conversation, and I'm going to turn it over to Dr. Chapple.
Hello, everyone. My name is Reshawna Chapple. My pronouns are she, her. I'm an associate professor of social work at the University of Central Florida. I'm also a licensed clinical social worker and a co-PI of the Advancing Health Equity for Adults with Disabilities from Diverse Communities Rehabilitation Training Center at the Center for Disability Health and Wellness. That is a whole mouthful. Although I am not a person living with a disability myself, my teaching, research, and practice centers around the intersections of race, gender, and disability. The majority of my work focuses on Black deaf women. My passion for this community was born out of my lived experience. My oldest daughter is deaf. I learned sign language when she was very young, and I continue to work with the community. And one of my best pleasures is she's also a social worker now, and she works for the California School for the Deaf at Fremont. So I'd like to set the context for this panel today. Today's event is part of our broader commitment to fostering disability inclusion in all health professions. We're centering allied health professionals, a group critical to healthcare delivery, but is often overlooked in conversations about disability inclusion. Our panelists are allied health professionals with disabilities who have navigated trainings and practices across various disciplines. They're here to share their experiences and insights to inform a more inclusive future for students and professionals with disabilities.
And before we begin, we want to extend our sincere appreciation to our main sponsor, the Center for Disability Health and Wellness, and our partners at the Stanford Medicine Alliance for Disability Inclusion and Equity. Many of you will know them as SMADIE, whose support made this panel possible. And sign language interpreters and captioning are available today for today's discussion. If you need any technical assistance, please use the Q&A feature. And please submit any questions at any time. I know for me, questions come up and I'll forget it if I don't get it out. So please use the Q&A feature to ask any questions at any time. We'll be monitoring that feature and we'll get to those questions. We've left a lot of time to hear your thoughts and to answer your questions. Our webinar is being recorded. That's usually the first question we get in the Q&A. It is being recorded today, and it will be on our YouTube page, the Docs with Disabilities page, in about 2 weeks' time. A link to the YouTube page will be put in the chat in a little bit.
Okay, so I'd like to begin. I'd like to ask our panelists to briefly introduce themselves. Please share your name, pronouns, disability identity, if you wish, your role, and your area of practice. The order of introductions will be Dr. Ayers, Dr. Joy, Macheel, sorry if I'm saying that incorrectly, Lori Goldberg, Dr. Erin Andrews, and Dr. Shah. I'd like to start with Dr. Ayers.
Hi, thank you. Yes, I'm Dr. Kara Ayers. My pronouns are she, her. I have a disability called osteogenesis imperfecta, which means the kind of the most well-known characteristic of my disability is that my bones break easier than most. But it also means that I'm a member of the little people community and I'm a full-time wheelchair user, and definitely identify proudly as a disabled person. I'm a clinical psychologist by training, and now I'm an associate professor at Cincinnati Children's Hospital. So there and through that role, I'm working on a number of different grant-funded projects related to my research interests, which are health equity, disability, ethics, and disabled parenting, among some others that I pick up along the way. But I'm really looking forward to the conversation we're going to have today.
Thank you so much, Dr. Ayers. Dr. Joy?
Yes. Hi, I'm Joy Macheel, she, her. I'm a physical therapist and I'm also an associate faculty member for the program in physical therapy at Mayo Clinic. And I was disabled about just 2 years ago from a medical complication, and I am a wheelchair user. I still am ambulatory for short distances, but I'm excited to share today.
Thank you so much. Dr. Goldberg?
Yes, hi, good afternoon. My name is Lori Goldberg, she, her. I am a speech language pathologist, and I have cerebral palsy. I have worked in various settings, including hospitals, schools, and private clinics. Currently, I am working for a large private practice in South Florida.
Thank you so much. Dr. Andrews?
Yes, thank you for having me. My name is Erin Andrews, and I'm wearing like a white top with some dangly earrings, and I've got a blurred background with my diplomas behind me. My pronouns are she, her, hers, and I am a board certified rehabilitation psychologist, and I work as the chief of psychology for the VISN 17 VA Clinical Resource Hub, and I'm also an associate affiliated clinical professor in the Department of Psychiatry and Behavioral Medicine at Dell Medical School at the University of Texas at Austin, which is where I live and work. My clinical work is focused on rehabilitation and neuropsychology, and my research interests are disability identity and cultural competence, disability inclusion and psychology training, sexual and reproductive rights of people with disabilities, disabled parenting, and reducing bias in disability language. Appreciate the opportunity to be here today.
Thank you so much. And last but not least, I think it's Dr. Shah.
Thank you so much. Yes, my name is Dr. Kruti Shah. My pronouns are she, her. I'm a clinical pharmacist with a background in inpatient psychiatry and transitional care, formerly at Rush University Medical Center and now at Oak Street Health. I serve on a number of DEIA panels or committee at the AACP, which is American College of Clinical Pharmacy, as well as Illinois level clinical pharmacy organization. And I self-identify with a disability of moderate hearing loss, which I was diagnosed when I was 3 years old. And I'm a hearing aid user. It is such an honor to be here today joining you all. Thank you so much for having me.
Thank you so much. I'll turn it back to Lisa.
Yeah, thank you. I'm so excited to have the opportunity to speak with all of you. And I'm going to start, Kara, with you and with Joy and ask you a question. What inspired you to enter your field of study, and was your disability a factor in that decision? And maybe, Kara, you can go and then Joy.
Yeah. My start kind of in the general field of psychology was I guess, kind of traditional in that I remember taking my introduction to psychology class in my freshman year of undergrad and just really loving it and wondering, like, what else could I do with this? And then definitely also realizing that this could be a potential fit for both what I like to do, what I think I'm good at, and also the physical aspects of my disability. As time went on and I planned to, go to graduate school to study psychology, I also started realizing that there were aspects, not so much of my disability per se, but of societal instances of ableism really baked into policy that also meant I would have to make specific decisions about my career. And so an example of that is as my friends in graduate programs were really excited to think about private practices, this was actually before the Affordable Care Act had passed. And so I was very aware that I was likely to be denied insurance, healthcare insurance, if I wasn't under a large group plan. So I actually kind of tuned out during a lot of those private practice discussions because I thought that won't be a path for me because I will always need to be employed by a large employer like a hospital, like a university, so that I won't be denied insurance coverage based on my disability. Between now and then, of course, the Affordable Care Act has passed, but I think we're especially aware right now that things could change. Right now, I am under, a large group plan at Children's Hospital, but I think we not only have to consider aspects of our disability itself, but also all these kind of policy related aspects. And sometimes we don't know about those. And so we're making career decisions without all that information that we need. I had some good mentorship along the way that helped me kind of know what options were out there. But the mentors that I happened to be kind of located around looked at disability more from a medical model perspective of the way that we treat disability by eliminating disability really. And so I was at that time doing a lot of my disability advocacy work kind of at night as my night job or as almost a hobby. So I really wish I would have had run into someone along the way that would have helped me understand that you can integrate advocacy into your career. It doesn't have to be this like extra thing that you do only in your free time, because when I became a mom, which was during my final year of graduate training, during my internship year, I realized that I didn't have the stamina nor just the time in the day to do, my full-time day job, to be a mom as I wanted to be, and then to also do disability advocacy work. So I'm thankful that I've figured out a career path now through some kind of bumps along the road. But disability has definitely factored in both the physical aspects. When I think about kind of what my career looks like, part of my disability is that I could break a bone at any point. And so it's important for me that as soon as I am able to return, that I'm able to get back to doing what I love and what I want to do sooner than what like a full bone recovery would be 6 to 8 weeks. And so that has factored in as well. I didn't know all this in the onset of entering my field, but I've kind of figured it out along the way and then done what I can as well to let other folks know that are coming up in the fields to consider, yes, your physical aspects of disability, but also things like stamina and kind of how you want to structure your days. If you're able to have flexibility, like working from home, that's been really important for me. So I figured it out along the way, but it was definitely a factor in entering my field as well.
That is so much good advice just right there out of the gate. But I hadn't really thought about the insurance implications of deciding between a private practice and a large hospital group practice. I find that really fascinating and so true, right? Especially before the Affordable Care Act. So thank you for bringing that up. Joy?
So my story is a little bit different because I was already in my profession when I became disabled. So I am a physical therapist, and up until about 2 years ago, the large bulk of my practice was working with people who had spinal cord injuries or strokes, so a lot of neurologic things. And I really knew my wheelchair vendor well. And so when I became disabled and needed a wheelchair, I was like, hey, Scott, let's get going. So it's given me an interesting viewpoint because as a physical therapist, I liked to believe that I had a very good idea of supporting my patients through whatever they were experiencing. But this has given me a new viewpoint on so many aspects. And I no longer see neurologic patients because it's not a safe thing for me. But as a physical therapist, there are so many things I can do. And I have a lot of specialties. I usually say my goal was to make sure I never had to see sports. So I do all of the things you don't think about PTs usually doing. So I still have many things I can do. I'm also a faculty member too. And so part of this, since my injury has been kind of considering, do I move more into a faculty role? But I still really enjoy seeing my patients, and I have been able to do many of the things I want to do as a physical therapist in my career still. So I think it's been a great opportunity.
Wonderful. Do you feel like as someone with a newly acquired disability, do you feel like this has changed your passion or focus in your profession? Obviously, as a physical therapist, you are passionate about patient care and passionate about optimizing functionality. How has your experience changed your perception of delivering healthcare?
I think it has, it's kind of, again, opened my eyes to what is possible, what small changes need to be made that more people could be successful in this field. Especially as a wheelchair user, truly it's space, can I get in this door? Our clinic is under a lot of construction, and there are times where I can't get in places. So I've really liked it to be, working with patients who also have disabilities, kind of problem solving things, and just really trying to, I think that empathy level, I think they believe my empathy a little bit more. And in terms of as a professor, it's really motivated me to kind of encourage my students that really whatever you are thrown, you can still be successful in this field.
Thank you. Reshawna, I'm going to turn it back over to you.
That brutal mute button. So our next question is transitioning over to practice. And this question will be for Dr. Shah, Goldberg, and Andrews. Before entering your profession, did you anticipate any challenges related to your disability? Dr. Shah, you first.
Yeah, thank you so much for that really good question. I feel like I have to spiel back my life by 20 years, just to start up the profession and figuring out, what landscape will I be entering when I started pharmacy school journey, a doctor of pharmacy program. The two things really pop in my mind. One is my own internalized ableism as a barrier. A lot of times I've made assumptions about my own ability based on my hearing loss, thinking to myself that maybe, I don't know, I'll always have to work harder to achieve what I want to achieve. I don't think I'll ever be able to progress in pharmacy career the way others would have progressed because I have a disability. So I feel like I had a lot of, or just assumptions about myself that I made calling myself an average student. And the other challenge that are anticipated were kind of working with and kind of self-disclosure. I think I remember feeling the stigma around disability. And again, 20 years ago, maybe disability wasn't as spoken about as, it was not easy for me to just, go in and say, yes, I self-identify with a disability. So I think that not having or lack of representation of disabled pharmacists was definitely one of the challenges that I felt that I will be facing, which has been true. And then lack of technology and awareness. Now I feel like I go to a lecture hall and I'm able to turn on captions, But back in the time, captions were a process. There had to be a formal request for captions, and it was not an easy process where you just turn it on. So I think some of the technological barriers, I would say lack of awareness about disability, just culture. And the other thing that I felt, and this kind of goes back to stigma, is that I, being a woman of color, and also my life has spanned over 3 different countries, being an immigrant, I felt like there was already a lot of marginalization that was going on. And to add another layer of marginalization, which is disability, I felt, where do I begin? So those were some of the challenges that made my pharmacy journey or education practice.
Thank you so much for sharing. I imagine that those intersections created a lot of doubt in your head, and it seems like you were able to get through that really successfully. Dr. Goldberg, can you answer the same question, please? You're muted.
Okay, thank you. When I looked at that question, it was actually interesting because my first response to that question was, no, I didn't see anything. I didn't anticipate any challenges. And it was sort of very short and sweet, my response. But when I thought about it, I've been in the field now for over 30 years. I don't know, maybe I'm one of the older people on this panel, but when I was growing up in the 70s and in the 80s, at least in my family and in the community, we didn't talk about disability. I was, for lack of a better word, as typical as everybody else, except maybe I walked differently and I couldn't run that fast, but I excelled in school. And I remember my parents and my grandparents saying, like, oh, there's nothing wrong. You can do anything you want. So I grew up with this mentality, you can do whatever you want. And so applying to graduate school, I always liked children. I knew I wanted to work with children in the field of speech pathology. And I knew that the field would allow me to work in various settings, depending on, where I was in my life. That was going to change significantly. Once I got into the field, I said, oh, children don't sit. Children are not all that well behaved when they're in an office with you. And I sort of got the cold water thrown over me because it was one of these, you need to respond, react, and process what people are doing all at the same time. And for a person with CP, moving quickly and knowing how to listen and react and respond and going back, those transitions were difficult for me, and they have continued to be, although I've developed strategies to handle that, but I didn't realize that going in.
Wow, that's a different take a little bit. A lot of times people have these fears and anticipations going into it, and you had that confidence that you got from your family, and then had to pivot a little bit.
Right. And, I say to myself, I could have decided to go down the adult path and just done adults. And I didn't. I said, I'm working with children. And I do a lot of work with autistic toddlers, used to autistic toddlers and preschoolers, and they are busy a lot of the time. And preschoolers run, they like to move. Probably not the best match in retrospect, but I've learned how to figure it out along the way.
It sounds like it's worked out pretty great. So thank you so much. Dr. Andrews?
Yeah, this is a great discussion. So I was thinking back, and when I decided I wanted to become a psychologist, I think similar to Dr. Goldberg, I thought, oh, that's kind of a cognitive job, and maybe my physical limitations, which I did not mention in my introduction, will get in my way. So my disability is that I'm a congenital triple amputee. So I just have one extremity, which is my right arm. So if you were to be in person rather than on Zoom, you would notice that my left arm is amputated above the elbow, and both of my legs are amputated through the hip. And so I obviously can't walk at all, and I can't use lower extremity prosthetics. So I use a power wheelchair for all of my mobility. So when I started graduate school, the first thing that I encountered as a barrier was that I had just learned how to drive a little bit older than most people. So when I was college aged, I learned how to drive. And that was because my family wasn't able to afford the type of vehicle that I would need to be able to drive. And so it wasn't until I actually was going to go to graduate school that I was eligible for the state vocational rehabilitation assistance that I needed to be able to get the vehicle and drive. But I realized right away that, this was going to be crucial because at the beginning in year 2, we had clinical practicums and we had to, go to these sites and get ourselves there. And it wouldn't be practical to be using public transportation because these sites were spread out all over the place where you might have a clinical rotation. And so that was one thing that was, anxiety provoking at the beginning, like, how am I going to get all of this figured out? But of course, I did, it came together. There were some hard times, but got through that. And then I think the second area where I experienced potential barriers was part of being trained as a psychologist means that you will be trained in psychological assessment, including like psychometric test administration. And specifically, as I went through my graduate program, I realized that I really liked neuropsychology and rehabilitation psychology. And I wanted to learn how to do those things. And I wanted a neuropsychology internship. So, there's some physicality to that. But most importantly, there's strict standardization. Things have to be administered in a certain way so that the tests can be, considered valid and reliable. And this is something that I've heard from a lot of psychology graduate students that has been a huge barrier where, their professors or their practicum supervisors are saying, well, if you can't administer these tests, then, you can't do this. Essentially, like you can't become a psychologist. And I was so fortunate. I had a neuropsychologist who is my professor in graduate school. And, I said, do you think this is going to be a problem at all with me just having one arm? And he was like, no, I don't think so. But he took the extra time to sit with me and make sure that I was able to administer the test. And if I had any difficulties, he and I worked together and we brainstormed, what could be a potential solution that would both work for me, but also still be clinically appropriate, for the patient. So I was very, very blessed to have had his supervision. And I've consulted, now in my career with a lot of training directors, trying to explain to them that it's not about the physical aspect of administering those tests. That's not what the psychologist has to do. In fact, a lot of psychologists rely on a technician to do the physical administration. What's important for the psychologist to understand why we're giving those tests, why we choose those tests, how we interpret those tests, and then how we pull those test results into the big picture for kind of more of a whole assessment. So it just surprised me a little bit how many people really don't realize that. Like, oh, if they can't administer the block design, it's really not that relevant, right? Because that's not what the relevant skill is. So yeah, those are a couple of things that maybe I didn't anticipate, but kind of ran into, but both of which were able to be addressed successfully.
Wow, thank you so much. I appreciate your answer. I'm going to pass it back to you, Lisa.
Thank you. Okay, so we have 2 standard questions we like to ask our panel in the effort to kind of enact this asynchronous mentoring, right? We have a lot of people in the audience and a lot of people who will be watching the video. And one of the things that they're going to want to know is, what were the biggest challenges you faced in the employment context? So I'm going to ask you that. Don't tell us your solutions yet, because Reshawna will follow up with asking about how, what were the biggest facilitators? I think this is really important, not only for the potential applicant to a program or the student that's already in the pathway or the clinician who is acquiring a disability and wondering how they're going to go back to work, but I also want you to consider that we might have clerkship directors or program directors or administrators of these programs who find their way to this video and think, I'll watch this and see what it says. We have an SLP, we have a PT, we have psychologist, pharmacist. What can I do to improve my program? So that'll be more in Reshawna's lane, but what were the biggest barriers that you faced in employment? And this is really for the entire panel. So if somebody wants to breathe that brave soul to kind of start the conversation, I have faith that you will all have at least one thing that was a barrier in your employment context. Who wants to begin the conversation? Oh, Lori, you're muted.
Okay, I'm happy to start, because from hearing from all of my colleagues, it sounds like many of them may have experienced similar issues. For me, throughout my career, accessibility has been a significant issue. Accessibility, starting with getting into the building, has been significant. Parking spaces, finding a close parking space has been difficult, and something that I've had to really reach out to attorneys over time, because the places were not accessible. When I worked in the schools, a lot of school therapy is 30-minute blocks. And teachers are busy. They don't have time to bring kids to you, and many kids can't walk on their own. So getting up every 30 minutes and bringing children to and from classrooms. Buildings, I worked in New Jersey for a long time. There were lots of stairs in the buildings, lots of floors. I'm currently in Florida. There's no stairs, but the buildings are huge. They are called campuses instead of schools. So as a whole, that has been a very difficult area for me. That's been a barrier that I've had to work hard at.
So physical accessibility.
Yes.
Yeah.
Yes.
And it's so striking to me. I think, I tend to be a little naive and optimistic. So I think, well, if you need a parking accommodation, then it's simple. You give your documentation to whomever this is very transactional, should not be a big barrier. Right. And when I hear from my learners, the hoops that they've had to go through to get something as simple as a parking accommodation, it hurts my heart. It becomes almost a part-time job for individuals to ask for, iterate, and receive and implement accommodations. So certainly we can appreciate that. And yes, Lori, the campuses, because they're all flat. So yes, that was a very big difference I noticed in Florida. How about others?
I would add, this is Kara. Yes to all the physical barriers. Those seem never to quite go away. But also for me, it has been just the attitudes and the presumptions of what I can and can't do. So people making decisions before they even ask me, coming up with like hypothetical things to worry about that are really unlikely. I remember one of my practicum settings that I had like really prepared for from the start of my program. I knew that I wanted this practicum setting in a major children's hospital in an inpatient children's psych unit. And I had like prepared, my courses that I'd taken and everything that I'd worked on to be a really good candidate for that practicum site. And I was selected. And then the hospital kind of panicked because they came up with these like concerns. And I had done some research on my own to understand, what was the practicum actually like. I had asked questions of trainees who had been placed in that same setting and asked questions like, what happens if a child gets aggressive? And they had explained to me, well, your role would not be to intervene anyways, that would be the role of a behavior check, that yes, you could be skilled in de-escalation, but mostly you get out of Dodge, like everybody else that's in your role. And so, but they also were explaining to me that, in this setting that really didn't happen that often. And so I had done my research, but was still faced with these assumptions about how I would be an added risk to the unit. There was even kind of like retrospectively a really silly discussion that I had with their risk management team about how they were worried that when I keyed into the locked unit, that a child could be waiting on the other side of the door and could wiggle. They described like a snake wiggle between the wheels of my wheelchair. Which first of all would be like extraordinarily difficult to do. Also, like, why couldn't you do that same thing between somebody's legs if they were coming through the unit? So I think for me, those attitudes, those presumptions of what I can and can't do, a failure of imagination, like people just deciding, well, you can't possibly like come to this conference because it would require, you to take an airplane or something. Like people don't, if they can't think in their head how they might do it, they assume that you can't either. And, a barrier that I still struggle with, and I don't know that it has like a perfect description, but I still have interactions with people that I know I need to like work with this person on something. And I can almost immediately feel that they are very uncomfortable around disability. And sometimes that's something that I can crack through and improve on. And sometimes it's not. And if I need to work with that person to maybe leverage funding or to figure out how to improve a program, it is very frustrating to know that just a part of who I am and my identity is making this more difficult. And so doing things virtually by Zoom has helped a little bit with that. But it comes even more apparent when, somebody can work well with me on Zoom. And then when we have an in-person meeting, they are like notably very awkward and uncomfortable around me. I remind myself, that that's not my fault, but that's something that I can't necessarily share a solution for, but it's definitely one of my challenges.
Oh my gosh. Well, thank you for sharing. And I can't imagine how that must feel, but I do witness that, right? As a third party, I witness the uncomfortableness, and it is hard. And it's, what causes that? It's like the way that we talk about disability when we think about all the kind of ableist tropes that are out there, and the way in which disability is situated in social exchanges and movies and television and all of these things. And I will remind audiences often, when do you recall the first time you saw someone who had a visible disability, and what did your parents say to you in that moment? Right? Because usually your child and the parents will say, don't stare, right?
Yep.
Don't look, don't do. And so what are we doing when we have those reactions as parents? We're teaching people to avoid contact, and we're, teaching them to internalize this idea that there's something wrong with engagement. So I absolutely hate that for you, but I'm so glad you brought that up, because I don't think it's something that gets brought up on panels often. What does get brought up that I also kind of want to follow up on is this idea of the locked ward and the limitations therein. And so I have heard this all the time, both as a DRP and then as a consultant, where if you're deaf or hard of hearing, how are you going to respond to people on a locked ward? If you are a cane user, how is that going to work? There's a lot of adversity or kind of negative response to the idea of a person with a disability going into a locked ward. And I don't want to put Kruti on the spot, but on the other hand, Kruti's prior employment experience was actually working on a psych ward. And so as a person with that utilizes a hearing aid, I know you have first-hand experience with this. I wonder if you might kind of build on what Kara was talking about, and then share your own experience with barriers. I don't want to list your barriers for you, but I know this was one that you've definitely dealt with.
Yeah, thank you so much, Lisa, for also summarizing our co-panelist responses. I'm honestly like enjoying being on this panel and listening to other people's responses. I'm like, oh, I forgot that I also wanted to share. And I think so. I used to be working at Rush University Medical Center as an inpatient clinical psychiatrist. And when I'm on rounds with physicians, with nurses, there was actually one particular patient case that I remember who did not bring her hearing aids. She happened to leave her hearing aids behind at home when she was admitted. And on top of all the other, feeling overwhelmed, being in the psych ward is like very alienating and also very overwhelming of an experience for that patient. And when we were rounding, I think I remember I could almost put myself in her shoes and understand that it's not just the, some of the psychiatric, challenges, but it's also the fact that she left her hearing aids behind and the tension that's created when they're not able to hear the doctor, who are sometimes wearing face masks. And I'll talk about that in just a moment, but like sometimes they're wearing face masks. And so it's hard for the patient to understand what the nurse is saying, what the doctor is saying, and also feeling delirious at times, or feeling, you're out of it. You're being asked something, but you're responding something else. And not because of lack of hearing, but you get written up as, or, not oriented. The patient is not oriented. And that's not necessarily the right assessment of that particular patient. But I remember her feeling really agitated. And after we walked out of the room, I think we talked about everything in terms of medications, what we're going to do, what the next steps. And I'm like, what about her hearing aids? We need to figure out a way if we can call the family member and have those hearing aids here. And in the meantime, we are going to use clear mask. And if I could take the opportunity and talk about how clear mask played such a huge role, because a lot of times people who are hard of hearing or deaf, we don't realize, but we rely on lip reading. My disability has been around since I was born, but I was diagnosed at age 3. But my relationship and the challenges with my disability has evolved over time. And one of the transitional or very key, life-changing event was actually unprecedented moment of COVID-19 when the pandemic hit. And I felt that in most situations, as long as I'm facing the person, I feel like I was able to communicate and carry on with providing the pharmacy care. However, once the mask, which is really important for public safety, once they came on, I could not hear what the other people were saying, what my colleagues, my nurses, my doctors, my patients were saying. And it's also the way the technology is. The hearing aids are not just powerful enough to amplify the muffled sound. I think it's just the way they're built. And so it considered background noise, and not going into technical details, but it's not as easy to hear somebody when they have a mask on. Now, 2020, and I'm having a hard time being present on the meeting, understanding what other people are saying. And it's not easy to just lower your mask and, say, hey, I need your mask to be lowered for the breed. And so DERG, for me, Disability Employee Resource Group as Rush, played such a huge role in advocating for clear mask. And it started out as like, hey, we need this clear mask because otherwise I'm not able to read people's lips. And it brought, once we acquired, it was a long challenge of 6 months, but once we did have clear mask, I remember feeling seen, feeling valued, feeling heard, and be present and included in conversations, no matter who that was. And that was a life-changing and positive experience when Clear Mask was on. I do think that the challenges that came with it were A, the challenges of acquiring Clear Mask. B, masking is a type of accommodation. It's not that you just take it and you say, okay, here are my clear mask, I'm going to wear it, I'm going to walk around. I actually need other people to put on a clear mask, and that adds a layer of discomfort for some people, because again, we were living in the strange times when we're worried about what if I get exposed to COVID-19, and if clear masks were not perfect, then people would feel uncomfortable. So I remember having challenges, or just telling my manager, hey, I need other people to wear these masks for, so then I feel that I can, have a conversation. And I think for communication needs, I remember everybody feeling slightly uncomfortable, which again, we were able to accomplish that over time, but if there's that barrier that I had to deal with for good 9 months. And then the other aspect that I wanted to mention, that's the almost like a positive side of Clear Mask, kind of like wrapping up the story that I started. When Clear Masks were started as advocacy efforts from employees, however, they actually were also then available for patients, for elderly, for pediatrics. Patient, and that was a game changer because the patients felt that they were able to communicate with their nurses and doctors. And so in that particular case, for our patient on the psych ward, once the Clear Mask was on, she was able to, even without her hearing aids, at least lip read and feel a sense of comfort with her care and trust.
It's so interesting to listen to the three of you because, Lori, you're talking about physical access. You're saying, I can do the work, I just need to get in the building. And Kara, you were saying, it's really about people's attitudes. If people would just, in Taylor Swift's words, calm down, right? If everybody would just calm down, things would be okay. Everybody knows I love me a good Taylor Swift story. And then, Kruti, yours is really structural in that it's really at the core, it's about accommodation, needing an accommodation, having to fight for the accommodation, then having to procure the accommodation, right? If there's a cost, that adds a whole other layer. If it's an accommodation where we can just step in and say, all right, well, we're going to give extra time on an exam, or we're going to allow somebody to leave. But the layer of purchasing something, so there's a financial transaction there, and then compliance with the accommodation. It wasn't just you. It wasn't just centered on you being given something. It wasn't an individual level accommodation. You needed cooperation. So that strikes me as such a multi-layered barrier, which is really interesting, right? I wonder, Erin and Joy, we've seen three different types of things. How have your experiences kind of aligned with this as far as barriers go, or what other barriers did you face?
Can definitely relate to the ones that have been discussed already, both the physical and the attitudinal. And I would just add that, working in a medical setting, I struggled to be taken seriously because people see the wheelchair, they see me, and they think patient, not provider, not doctor. And so that's been ongoing, issue. Like when I would go into a inpatient rehab unit, sometimes I'd have these experiences where there would be like religious folks coming to pray with the patients and stuff, and they would see me and then they would want to pray over me. And I'm there to do my job, right? And so that would be sometimes uncomfortable or disruptive. And then from a physical aspect, it's just interesting. Again, my experiences are in healthcare, but there may be accessible spaces and places for patients, but they're not for staff, because the expectation is, well, the staff are non-disabled and so they wouldn't need those things. And so that's a big barrier of always having to, be like, yes, but I'm not a patient, but also staff, can use these things. And having to advocate too, like, hey, guess what? This automatic door is not only going to help me, it's also going to help people with their hands full and people with strollers, and just having to be constantly advocating.
That must be, I don't want to put words in your mouth, but I'm exhausted listening to you describe it. And I feel like you're trying to do a job, and then you have to do the job of managing everyone around you. And no one's offered to pray over me. So, that feels also just very invasive. So having to manage that. And I know oftentimes individuals with disabilities, especially individuals with disabilities that are parent, will say, I find myself working to make sure other people are comfortable, and that shouldn't be on me. But it becomes part of the issue when you're especially delivering patient care, and if a patient's uncomfortable. Thank
Yeah,
you
you
for
have
sharing.
to. You have to do it. And it shouldn't be our job, but we have to do that. And it is extra work.
Absolutely. Joy.
I would say mine are very similar. You know, most of mine is physical access, but also, yes, dealing with or interacting with patients because at my clinic, at our outpatient clinic, I have to wheel myself out and go pick up a patient. So I wheel them out and patients will look at me and it's very much that like, wait a minute, how are you going to help me if you're in this wheelchair? And sometimes it is a little bit of that navigating. I'm a very open person. I'm a pretty open book. So I'm willing to have conversations with patients, but then there's also people that then try to turn their appointment into like, well, what's going on with you? And it's like, there's a little bit of that. We don't need to talk about what's going on with me. Actually, my favorite response I just saw about like, what do you tell people when they ask why you're in a wheelchair? I saw, oh, I asked someone about their private information, medical information. So, but yeah, so some of it is, again, it's another layer of trying to prove that I actually know what I'm doing, because there is that degree. Sometimes as a woman in physical therapy, people didn't trust that I knew what I was doing. And now that I'm a disabled woman in physical therapy, it's another layer. Mm-hmm.
Yeah, those layers, like, Kruti was saying too, like how many layers of barrier do we have in the assumptions and the attributes that are placed on us that are not true? When Kara was talking earlier, I was thinking about my time in admissions and all the times that the admissions committee would start talking about an applicant and layering things that weren't there. They weren't in the application. And of course, so me and my stocky would say, could you show me where that is in the application? Right? To kind of to ground people in the evidence. Like, how do we know this? We're making a lot of assumptions here. How do we actually know that this is something that would be a barrier? Well, I have great news as I turn it back over to Dr. Chapple, because we have a run of show and we are ahead of schedule. So audience, we're going to have a lot of time for those questions. It feels so good because I had another talk today that went late. So please start populating the Q&A with things that you're thinking of as our amazing panelists are giving their experiences. And Dr. Chapple, turn it over back to you.
Thank you. Yeah, I was just getting ready to say that because I'm seeing some questions and they're really good ones, but I know we have time at the end to get all of these questions asked. So we are going to start talking a little bit about solutions and catalysts and things that have helped us get here. So this is, again, to all the panelists, and you can either give us a new story or you can kind of add on to something that you've already talked about that's a challenge. We know that there are catalysts that reduce these challenges. Looking back, what was one of the most significant educational or workplace catalysts? A person, a policy, some sort of advocacy that contributed to your success? I know we heard a couple, the clear mask and Dr. Andrews mentioning that instructor, but we're looking for a few more, just some ideas about some things that really helped you along the way.
This is Kara, and maybe it sort of factors into one of the questions that we can talk more about in the official question and answer period as well. But the question from Erica about like, how do you find that balance of workload balance and considering like stamina related to disability and all of these things like balancing patient care, teaching, administration work. And so I was really fortunate that when I interviewed for sort of the position that I am now in today. At first, I was not hired for that position, but I was hired for a different position within the USED, and USEDs are University Centers for Excellence in Developmental Disabilities. There's one in every state and territory. And so my director at the time, and who ended up being a mentor and a catalyst for my career, she asked me because she knew that I had not been hired for the position that I had interviewed for and wanted. And so she asked me at that time, can you write just a one pager of what your dream job would look like? And it really helped me think about what that would look like. Like, what percentage of my time did I want to do research? What percentage of my time did I want to do teaching? And so kind of having in mind what that looked like then allowed us, and I mean, it took years to build, you know, grants around that, and eventually for me to apply for a different position and get a promotion. But knowing kind of what your goal would be helped me, piece by piece kind of build that. And I'd never been asked that before. I'd never, really let myself think about it in that way. So for me, when I look at like what catalysts for positive change have been, they really come back to people, mentorship, and people that have just so generously given me their time, and also sometimes shared with me some observations about things that I can work on, and let me know too things like, rest is okay, and rest is part of getting through life for all of us. But I think for me, it's been challenging to, um, counter those internalized ableist messages of you have to be better than everybody else because you have to overcompensate. And so, of course, you can't like take time off or rest. So I've really appreciated honesty, even when I didn't want to hear it sometimes from mentors, and that's been a major catalyst for me.
Anyone else?
Yeah, I can share. Thank you so much, Dr. Ayers, for sharing that, because I think self-care is so important to, we take care of patients, we take care of learners, and I think it's really important to practice self-care. And I've learned it so much from some of the mentors and coaches who are and that kind of ties into who were the people who, and I'm so blessed to be at a healthcare system that I was at Rush University Medical System, where we access, equity, diversity were not just buzzwords. And even right now at Oak Street Health, the whole model is value-based care, putting the patients in the center. And I know that access is something that is very, very taken very seriously. Sometimes people don't know how to do it because there's new challenges, as we talked about, clear mask. I mean, there's so many layers of challenges because, as Lisa mentioned, cost. And so I feel that understanding that some of the challenges that a particular institution is facing can be solved when you have the right mentors in place. Executive buy-in, we talk about, leaning in on shoulders of those who could then advocate for access, whether that is for patients, for employees. Some of the other things that is important, and I want to actually take a moment and thank Docs with Disabilities, because listening to podcasts, having those stories elevated has definitely has had a tremendous impact on me, because a lot of time disability can be isolating. It feels like we're in silo, and when you hear other stories, you feel validated, you feel that you're not alone. And I know we all know in our minds that we are an amazing healthcare professionals because of our disability. And I care double layer for my patient, because I know the lived experience of feeling, of living with a disability, of having communication challenges, whether that is, with a patient, whether with a doctor in person or on the phone. How can we make our healthcare, whether that is for learners, for employees, as well as our patients, how can we empathize with them? And I think for that, we need platforms such as Docs with Disabilities. And then I've been very, very fortunate to have advocacy support through Disability Lead. It's a Chicago-based fellowship organization, but there's so many, disabled and disability leadership fellows or fellowship programs that I think we could take advantage of. Connection and collaboration is huge, especially as healthcare professionals. We know that we can do things together when we're collaborated. So thank you. That's a really excellent question.
Thank you so much, Dr. Goldberg. Sorry.
Yeah, I think for me, finally making the decision, which was really in the last few years, I can't do these large campuses. And I need to begin to advocate for myself. Things are getting harder as I'm getting older. And I said, I'm going to look for a job and I am going to really advocate. And the job that I'm currently at, I said to the owner, who happened to be a PT, so that did help. I said to her, I have CP and I'm a good therapist, but I can't run after these kids. I cannot have young kids. They need to be able to sit at a table. And, we've been down this road before with many other jobs, and people say, yeah, we'll help you, but they don't. And my boss said, we will do this for you. And to date, it's been 2 years. They have never once stopped doing it for me. So that really was the catalyst to finally say to myself, I'm going to say what I need. And if they can't offer this to me, I'm not going to take the job. I'm going to wait for the guarantee. I think I'm worth it at this point, So.
Thank you. That was great. Just a quick follow-up, and maybe Dr. Joy, Dr. Andrews, you can tell us, how did you shape your journey in thinking about some of the obstacles and some of the other things that you had to go through? And maybe, I know, Dr. Joy, your disability is recent. Do you have any thoughts about the kind of the differences of the way in which you think about your journey and how you got here?
Yeah, I suppose it's like I kind of mentioned, it's changed where I have focused my patient load, and it's kind of changed what I want to accomplish, I guess, or just more so having to think about how can I still do the things I want to do, and what accommodations would help get me there. So most of mine have been, again, some like physical things, like at work currently. Like I mentioned, we're under construction. There was a pathway that I was using, and one day I went in there and the floor was gone. I opened the door and there was not a floor. And the other way to get around had a new construction door that had a 3-inch lip. So nobody had thought about that. My managers now, though, talking about people that are helping and being mindful since that kind of wild time of no floor and having to jump 3 inches in a wheelchair. They have been very accommodating. Even this morning, one of my managers came out, they put up a new false wall. And she said, when they were putting that up, we were measuring to make sure you could still get in. And then she's like, can you get into your office if you have to turn that corner? And I said, yep, I'm good. So it is kind of that awareness piece of maybe the floor has to go out, and then people will say, oh, okay, we need to think about you a little bit more.
That's great. So just people understanding that there are other people to consider and other things to consider when they are making these rapid changes of buildings and structures.
Yeah, and I can chime in here too to say that some of the really, I think, good things that have happened in my career is my own process of learning to. So when I started, when I was very early in my career, I was constantly trying to like mitigate any effects of my disability, which I think was very much encouraged and even expected. And as I became a psychologist and I advanced in my career, um, I started to feel more confident and more comfortable in handling my disability in a way that has been more useful. And by that, I mean, it's sometimes the elephant in the room. My specific disability is very visible and obvious. And so oftentimes, patients are going to notice it. They're not expecting their psychologist to be in a power wheelchair. So instead of like just being uncomfortable, or trying to, deflect their questions and stuff. I mean, obviously it's still a balance, and I don't get into, my stuff in their care. But what I found is can be so helpful is that it lends a bit of credibility to my work. So for better for worse, people that I work with assume that I've been through some stuff. And so it allows them to feel more comfortable to open up to me and to feel like, okay, this is somebody, maybe she can understand some of the things that I've been through. It can also have the opposite effect, which is sometimes I'm working, especially with individuals who have a non-apparent or non-visible disability, and they'll say things like, I don't know if I can work with you because, I mean, obviously, you know, what you've got going on is so much more difficult than what I've got going on. And that's such a great opportunity to talk about why is it that we make that assumption, right? And what has society taught us about disability and the fact that your disability is not visible? How does that make things more challenging for you? And it just opens up this whole door to conversation to where we can get to a common understanding that even though our disabilities are very different and we do face different challenges, we also face some of the same challenges or two sides of the same coin sometimes. So I think if anything, I would say that my disability has helped me be a better psychologist. And I also think even beyond patients, I think that for other healthcare providers, it's very good for them to have experience working with a disabled colleague, uh, because I think that it widens their horizons and makes them think, you know, of their patients in other ways. Like this, today's patient could be tomorrow's parent or tomorrow's physical therapist or doctor, whoever. So I think it is very positive. It is a lot to carry, right? It's not my job to like change everybody's mind about disability or, you know, be a positive role model all of the time. But by and large, just me doing what I do has been more positive than negative. So those are some of the things that I was thinking of there.
Well, thank you all for sharing. And that just leads so beautifully, Erin, into our next question for the entire panel, which is, how has your disability shaped your approach to patient care or to your research? And there is a kind of hypothesis out there that being disabled contributes to better patient care because the care is informed by your lived experience of disability and also helps shape the way we address patient care for all patients. So that just by being in the room, you are helping inform the system on better ways to care. So with that in mind, in what ways has your disability experience helped inform your patient care or really your research as well? Anyone want to start?
I feel like I kind of just answered this
Yes,
question.
you did.
Sorry about that. But let me just
That's
add
okay.
to it the research part, and then I'm going to turn it over to everybody else. So I think that, you know, historically, at least when I was in graduate school, you know, there was very much this mentality of like, we do research, not me search, if you know what I'm saying. Like there was a big stigma around um, people self-identifying and bringing that into the research space. And the assumption was you're inherently biased, like you're inherently bringing bias to the research with zero acknowledgement that everybody's bringing bias to the research, right? And so I've seen a shift and I've benefited from the shift and hopefully even maybe been a part of the shift in pushing to um, get some accountability in research. Like you're doing research about people with disabilities, but you don't have a disability or you don't have any real connection to the disability community. Like I think you should say that, right? Like I think that our identities and who we are and what we bring to the table are really, really important. And so more and more I'm seeing identity statements. I'm seeing, you know, journals ask for, you know, your kind of positionality. How do you relate to the people that, you know, you're working with? Because there's really, I don't think there's any other group where, well, I don't know, maybe this is like this in lots of groups, but all of this research is being done and the vast majority is being done by non-disabled people who don't have the lived experience. And sure, some of the time they're doing, you know, participatory action research or consulting with the community. And I am seeing that more and more. But by and large, research has been all about us and totally without us. And so that I think is changing. And I am really excited about, and hopefully, like I said, been a very small part of that.
Absolutely. I happen to know, I'm smiling because I happen to know there's a paper coming out that actually evaluated that. And I think it's interesting because I think most people did not disclose disability if it was invisible out of fear, right? Most researchers, I think, to have the research taken seriously, they were fighting against the issues that you were just discussing. So it's really interesting to me. And I'm going to let everybody else answer, and then we're going to go back to Reshawna for our final question. So how has this informed your practice? Anyone else want to chime in?
Yeah, can you hear me? Oh, great. Okay. I wasn't sure if I was on mute or not. I'm having an issue with the mute. Um, I'm a speech therapist. I was never in speech therapy. However, I have been in physical therapy on and off for my entire life. So I know what it's like to be in therapy. And I also know sort of what kids need in therapy now that I didn't get when I was younger, because the field was just not there. And I always tell physical therapists, they're my favorite audience because I feel like I can instruct them, and I always say, when I was younger, physical therapy was about, and I went for probably 10 years, 10, 12 years straight, 3 times a week. I would get left in a room. The physical therapist would say, I want you to do 10, cat camels or whatever, and then I'll be back in 10 minutes. And of course, I was a kid and I didn't do anything. And I feel like now what physical therapists are doing is they're making it enjoyable for kids. Therapy is now an enjoyable thing to do because kids don't necessarily want to be coming there. You have to make it, you have to make it fun. So I have really used that to help inform what I'm doing, the fact that I remember what it was like. And I also, for patients that I have who have similar degrees of disability, I'm more open in sharing. And I'll sometimes kind of whisper it to the kid, and, I have CP. I know what it's like. And it sort of changes their perspective on sitting there, because it's like, oh, somebody else gets this, So that's been something that's evolved for me.
Thank you.
Kara, I know I mentioned earlier that the medical model was always kind of pushed on, and I think it's been pushed on many of us in terms of how we think about disability. But as I learned more about disability justice framework of disability, that's had a major impact on my patient care and research. And so disability justice is not just the connecting of those words, kind of like we have other, fill in the blank justice. It's actually 10 principles. And so I won't share all 10, but of the principles that really impact my work the most, I think value for interdependence really is near the top of that list, because independence is so falsely kind of pushed as the only way of being, and none of us are truly independent. I mean, I don't think any of us live off the grid, but the type of help that we get as disabled people is looked at differently than the type of help and community collaboration that other people get. Also recognizing intersectionality, that we all have many different identities that contribute to who we are. Today, this discussion, we're mostly focusing on disability, but we could focus, on many pieces, and all those pieces combined to make up who we are. And then last, just the disability justice principle that all bodies and minds have strengths. And that is such a, counter way of thinking about how disability is often portrayed in our society. Sometimes if we're lucky, we'll have headlines like, well, I don't consider this lucky, but headlines like, person overcomes disability to do X, because our society really believes that to be successful at anything, to do anything, you have to overcome disability. So that idea that there are strengths in all of our minds and bodies is one that has definitely impacted all of my work.
Wonderful.
Let's see. Does anyone else have anything to share on that question?
I'll go really quick. I just wanted to mention that a lot of healthcare professionals, you probably see that we have such a great diverse panel of research, education, patient-centered, patient-facing practitioners as well. And I wanted to mention that within patient, centered, telemedicine is, I'm not sure if my voice is coming through. Okay, I know that it's breaking. Okay, telemedicine and virtual care, a lot of times, elderly patients are not able to access their appointment. And so then when possible, I feel like telemedicine has kicked in, and that has been something that has informed my practice, and which is why I moved away and now fully remote and able to practice in telemedicine. And so that helped me. And honestly, from a perspective of an individual who's hard of hearing and has, communication, I get what is called communication overload or hearing fatigue at the end of the day, multitasking, many people talking, noisy environment. So working from home has been something that I felt has been a game changer, because now I'm able to focus on what's in front of me, and that is the patient. And so telemedicine, again, I think as technology is evolving, I feel that there are more and more options open, and that's what I've kind of pivoted my career to telemedicine and transitional care.
Well, thank you so much. I want to pivot to the last question that we have before we go to Q&A. And this is for any and all of you. What advice would you give to students with disabilities hoping to enter the allied health professions? Things like advocacy, self-advocacy, mentorship, community, institutional change ideas. What is some advice you have for them? Big question.
You don't have to advocate alone. So I don't want people to see self-advocate and think that they need or should have to do it all on their own. But I also feel like that in almost every circumstance, you will always be your best advocate. So I think it's important that we lead our advocacy efforts for ourselves, but don't feel like you have to do that on your own either. Seek out mentors and don't be afraid or feel ashamed of that. Many of us are excited to work with mentees. I know it gives me an infusion of energy that I need. It's one of my favorite parts of what I get to do. So don't be shy in seeking out mentors.
Thank you.
I'll be vulnerable here and just share that, I've mentioned captions briefly, but I will say that when I went to, or I sign up for professional organization, when we're in a setting, when it's a large, kind of conference room setting, and there's a podium and a microphone, there are times when, especially for communication, that some of it will be missed when I'm in the audience. And so what I have done now is to ask ahead of, as soon as I'm registering or before I'm registering, hey, I would need captions. Do we have, or is this conference accessible? And I remember reaching out to mentors, because before, and my journey has evolved, because before I think, oh, I'll just figure it out, or I'll sit in the front row just so that I can lip read, but not put the question on the organizers, because I'm thinking I'm like, man, they already have so much to prepare. But not thinking that, what about my access? And to kind of then realize that, okay, I put my hand up, but then so many people actually said, oh my God, having captions was amazing. I'm so glad you have that. So again, I think sometimes as you mentioned, that we sometimes have to do it alone. And, when we do it, we realize that if the organization is really committed to access, that there will be that, and you will be benefiting so many people, not just yourself.
I just want to piggyback on what Dr. Ayers was saying. You bring, or at least in my case, I bring a lot to the situation. And I think for so many jobs and for so long in my career, it was more, oh, that I got a job. That's great. Now I'm going to go in quietly and do my job and life will be good. As opposed to, you know what, this is what I need in order to do my job and to be the best that I can be. And I'm going to tell you up front. And I think that that's important. A lot of people don't want to be open and say, I need this because you've already given me the job. But say what you need and you'll be surprised, because it's not that difficult to get what you need sometimes.
If I can go off of kind of all of that too. And again, as someone who came into disability later, I feel like my advocacy is by just taking up space. Like, I deserve to be here. Yeah, and I am good at what I do. And so I say, if you're going into these professions, we need you. We need your background. We need your experiences. And our, healthcare system, our patients are only going to be better because of you. And kind of like the other panelists have mentioned, by you asking for those accommodations, you're going to be helping somebody else. My 7-year-old kiddo said to me recently, how come everywhere doesn't have ramps inside? Because everyone can walk up a ramp, but not everyone can go upstairs. And I'm like, yeah, if a 7-year-old can figure this out, we can all get there.
The 7-year-old doesn't have the layers and layers of society's nonsense, right, to filter through. So yeah, I love it. Love children. Well, we have a lot of questions from the audience. So how do you all feel about getting to some of these? We have about 10 minutes left. We'd planned for 15. So we're still doing okay on time. But this is a really good one asked by an anonymous attendee. And I think this is important. What tips do you have for handling someone who invades your personal space or your privacy? For example, the example Erin gave of someone just praying over it, coming up to you and starting to pray over you. How do you handle that? I'm sure you've all experienced some sort of kind of boundary issue at some point related to your disability. Anybody, maybe 2 people want to respond to this one? Any good advice?
I can respond since I'm the one that brought up that incident. And I think it relates to another question too, about me being mistaken for a patient. But I think, being assertive, and this is harder when you're a trainee because you just don't have the confidence or the experience. But it'll come. And it's just being very assertive and firm. I do not like to be touched. Please don't touch me, right? Like things like that, saying things like that, and having, feeling like you have the agency to say that. Please don't touch me. If I get asked intrusive questions in like public spaces, I'll often say, I'm not prepared to discuss that right now, or uh, sometimes I'm a little snarky and say, I'm not taking questions at this time. Things like that, so people can kind of get the message if it's on an elevator or whatever. But the person that asked, do I wear a lanyard? Do I wear a white coat? Great observations, because when I was younger, when I was in my fellowship and early years of practice, I would put on the white coat because it was a symbol. It's a symbol, right? So for a lot of people, it's like, oh, I don't wear the white coat because I really want to relate to my parents or my patients, my parents. But if you have a disability, like that actually is a symbol of authenticity, right? Oh, okay, this person is, right? And then the lanyard to, showing that I work here. But I just want to say, like, those things are secondary. The first thing they see is person in a wheelchair, and that connotates patient, not provider.
Absolutely.
Yeah, I just want to comment on that because I was thinking about that. I've gone through, since starting my career, various ways of handling this invasion. And again, I work a lot with children, and children will often say things that adults won't say because they've learned manners over the years. And I've gone through different sort of levels. It depends on how the comment or question is coming across. I will often get, "What's wrong with you?" That's a kid. And it depends on how I'm feeling. And I may say, "Oh, you know what? Do you have a few minutes? Come on over. I'll tell you." Or I used to actually hold in some of my speech groups where I would see kids. I would say, "I know you all want to know why I walk like that. And let me talk to you about the brain." So I went through my phase where I would sort of instruct them. And now I sometimes I'll also say, you know what, that's not the way you ask somebody. But I'm very happy to answer questions for you. So it's kind of, it depends on the person and the situation, how I respond.
Yeah. Yeah, I think too the kind of perceived intention of the question as well really kind of matters. But as far as personal space, so one thing I do want to say about this is, you know, you have the right to protect your personal space. And so I think for some, backing up or rolling backwards as a nonverbal cue to someone that you're making them uncomfortable. But I just want to say, as a woman and a person with a disability, although it's not visible in most cases, that I just want to support the person asking the question to say you have the right to protect, you know, your personal space to your level of comfort. There's another really good question about accessing medical accommodations as someone goes into training. And so the question really gets at, you know, how do you manage the transition to a career and asking for accommodations in the workplace versus perhaps the way that you manage them in the educational space? Anybody, maybe one person?
Yeah, this is Kara. Sometimes the hardest part about this can be finding out who you need to document your accommodations with. When you're a student, it's often a relatively clear path, although it gets a little murkier when you're a graduate student, but that you should work with your accommodations through your disability services office, whatever they may be called. But as an employee, it can be less clear and, you know, you can kind of get the runaround. If you're fortunate enough to have an employee resource group or an affinity group affiliated with your university and or hospital, if that's where your setting is, those folks can be a really good resource to help you kind of know who to contact, how to contact. So unfortunately, again, it often involves more time on our end, finding out who to ask and how to ask it. But it is so important, and I can't urge people enough, especially I think in our current climate, to get those accommodations documented, even if, you know, they've kind of been on a handshake and agreement kind of basis for the last several years. And I know this is something that I do myself. I'm fortunate to work with a number of really great supervisors who know my accommodations, but in some years past, they haven't necessarily been documented in all the places. But you know, at any time you could have a supervisor change. You also could have a policy put in place, for example, the elimination of remote work that we're seeing in a lot of settings where if you don't have that described as a disability related accommodation, you'll find yourself, you know, in a really more difficult uphill climb to be able to reestablish that, if you're able to reestablish it, if remote work is ended for all employees. So get them documented, but I know it's sometimes hard to figure out how and where.
That lack of transparency is something that really bothers me, because I think it's the easiest thing to do to remove a barrier to people is to tell them exactly what to do, right? And it also helps reduce some of the anxiety. Well, I'm terrified to look up and see, we were quite on time. We had 15 minutes reserved for Q&A. It is 3:28, folks, and we end at 3:30. And all I can think is, how do I get all these people together again for a simple Q&A? No questions that are posed, but just a big Q&A panel. There was also a question about contacting our panelists, and so we're going to collect that information. We'll make that available on our YouTube page. Like I said, this recording will be up within a few weeks. And, you know, Reshawna, this is our third or fourth panel together.
Yes.
I'm really thinking we need to twist some arms for one more that's nothing but a Q&A with people coming back from all of our panels, because our audiences are so great and they have so many great questions. So we will put contact information as people want to make it available in the recording. As always, we are so grateful for the community that we've been able to build, and to our partners for supporting these panels. And hey, partners, we're going to ask for more support for that again. And especially, I just want to say, in these times, people with disabilities are really struggling with kind of the narrative around what it means to be disabled. And so I'm so proud of the work that we're doing, Reshawna, the work that we're doing together at the center, and all of the people who show up and share their stories and help combat the assumptions and the stereotypes that are uninformed is the word I will use today. So we really appreciate not only our panelists for helping us dismantle the stigma, but to everyone who shows up to take part in these conversations. And we'll be reaching out to you, asking you for your feedback. And please be on the lookout in our social media and our website again for perhaps a wrap-up Q&A only session where people can bring their questions. And I don't know, Dr. Chapple, if you have any last.
I just wanted to echo everything that Lisa said and just really, really thank all the panelists for your time, your honesty, your leadership, just giving us your wisdom. And we definitely, again, want to thank our sponsors. We just appreciate these types of conversations because the stuff that you say, a lot of times people who don't have, the lived experience, don't have the understanding. As much as we learn, there's always more to learn. So we just appreciate you so much. Thank you.
Thanks, everyone.
Thank you.
Lisa, I'm going to stop recording now.
Thank you.
Great panel. And I'll get the files over to you as soon as I can. May have to bring in some assistance.
Okay. Thank you so much. Thanks.
Bye-bye.
And Reshawna, I'll circle back with you. We